Hello, and welcome to the Wild Blue Podcast, perspectives on aviation lives, lifestyles, and business.
Hi, and welcome to the Wild Blue Podcast. This is Chris Kirk with Todd Mitten. Todd, welcome.
Good morning, Chris.
Yes.
Nice to be back.
Good to see you. We got a really cool podcast lined up for you today. Sitting here with us is Dr. John Owen, also known as retired Brigadier General John Owen. And John is Aviation Medical Examiner. He happens to be the guy who very graciously gives me my first class every 6 months. And then Todd also bought an airplane from him at one point in time.
Yes, that is true.
But anyway, hey, we're excited to have you here, John. Thank you. Give us a little background on who you are.
Great. Well, thanks for having me, Chris. I'm a Aviation Medical Examiner. I spent 4 years on active duty in the Air Force, then 24 years in the Air National Guard while practicing medicine in Liberty, Missouri. I'm the Vice President for Emergency Services for a Level 2 Trauma Center in Liberty and do aviation medical exams and consulting at ATD Flight Systems. My company's called Kansas City Aviation Medicine, and we have a good time doing it.
So if you happen to be a Kansas City listener, you know who he is. Somewhat of an icon around here, I would say. Everybody knows who you are.
Yes.
At least if they don't, they probably should. But Todd, you're getting ready to say something.
Well, I was going to say, is that it? Because no, it's really not even it, to be point blank honest. And we'll get into more stuff because he's also a very active pilot and at times a professional pilot. And I don't mean that derogatory. I mean, you always call it professionally.
Well, I'm sitting with two professional pilots. So I hope not.
No, but you have flown professionally also on top of everything.
But you're CFI.
The CFI, ATP rated, have a type rating in 500 series citations and fly 550 and 560 citation.
And so I know you've been multiple airplane owner.
Yes.
What are you flying now?
I fly Bonanza and also fly a SR-22 Turbo Cirrus. And then again, for the citation, I fly with a equity jet here on the field.
So I've known you for probably, trying to think, it's probably been 10 or 15 years. I've been going to you. But Todd goes back.
This is a good story. We met, Dr. Owen and I met at a flight instructor refresher clinic when you used to have to attend those in person, but I was a mere flight instructor trying to get recurrent. He was a guest speaker. See, that's always the difference, you know. I'm just there as a student. He's there. So that was right here on the field at Downtown Airport, 1995. And from there, we talked about the Air National Guard. And since you had been an active duty flight surgeon, you were interested in joining the Air National Guard. Why don't you tell us a little about that, how that came about?
Well, what happened then actually was I was on active duty for 4 years. I always wanted to be in the Air Force. I had family members in the Air Force. I grew up looking at my dad. We were somewhat impoverished in southern Missouri. Our entertainment would be to go get a hamburger and sit at the airport, which was about 50 miles away.
What airport?
50?
Yeah, 50 miles away.
Joplin. Yeah,
we'd drive to
that's
Joplin.
what I thought.
And they had some commercial air going in and out there, and we'd watch private pilots. And never really, even at that point, thought I would ride an airplane, much less pilot one. So when it came time that I was accepted to medical school, I didn't have any real means to pay for it, and all I had was positive thoughts about the Air Force due to my family members and interest in the air. So Air Force and I came to a contractual agreement to pay for my medical school, and then I was on active duty for 4 years. What I wasn't prepared for was enjoying the mission so much. There's a lot of things not quite so enjoyable about it, but the mission and the accomplishment and the people you work with was so positive that when I was getting out of the Air Force, I joined the Kansas Air National Guard. I was a flight surgeon over there immediately after getting off of active duty, and then was there for 14 years, had great 14-year experience. And then after 9/11, actually was recruited to come to the Missouri Guard to be a state air surgeon, and we put together a Homeland Defense program that was modeled around the nation and is in fact still in place, slightly different name, but still in place, that Air National Guard participates in all homeland disasters as well as being ready for any potential adverse wartime activity.
So as a Missouri Air Guardsman, and I got to know, I mean, I met John and knew him in the interim because then he became my family doctor for a period of time when he had the family practice in Liberty, or our family doctor, I should say. And then, though, knowing him through the Air Guard ended up being a lot of fun because eventually I ended up at state headquarters, and General Owen by that, well, you were a general by the time I got, I don't remember, either you were still a colonel, but eventually you were a general there, and rose to the director of the Joint Staff. Is that the accurate title? I'm losing it from my.
Yeah. It's a little bit of an unusual pattern. I was a flight surgeon, then the state air surgeon. Once we set this program up, that was by all accounts successful, was actually chosen to be promoted and be the chief of staff. So I was the chief of staff over a fighter wing transitioning to the B-2 at Whiteman Air Force Base, and C-130 unit and a couple of other units in the state that did that role for a while, and then was asked, that was in the height of the war with Afghanistan, and was asked to dual hat the director of Joint Staff and the Air Mobility Command assistant surgeon general. So did all that. It was about 200 pay days a year, so it kept me pretty busy with my military duties. But that was really a unique opportunity, and certainly spent a lot of time in Europe and AOR supporting that mission.
Well, I do want to bring this up, and I don't know if you know about this, Chris, but and General Owen will have to describe this in more detail, but he was directly responsible for and pioneered a system of evacuating wounded people, wounded airmen, soldiers, whatever, that made a huge difference. And so could you describe that program? I mean, I know you're going to be modest about it, but this is a big deal.
Well, the program I think Todd's talking about is the program where the Air Force already had a robust AirVac program set up, but it was really based around the C-17s and flying them in and out of Bagram Air Base, mostly in Afghanistan. We went out of Balad in Iraq. There's simply two issues. There simply weren't enough airframes, and there weren't enough medical personnel as well as pilots to accomplish what we were trying to accomplish. They were doing a fine job, but felt like we could improve it. So I looked around, and as an Air Mobility Command guy at that point, and I'd worked on it some actually before, is we used the 190th Air Refueling Wing in Topeka to pioneer a AirVac mission. And well, the KC-135 has an incredible range because it's an air refueler. It wasn't the spacious cargo area of C-17, but we could get there, and we could convert one in just a few hours to an AirVac model, and could go nonstop to Afghanistan if needed. Coming back, we could actually go over the pole when the relationship was a little different with Russia than it is now. We could actually go north out of Afghanistan and end up in Washington, D.C. with burn patients or people. Wow. And we could do that, and we had done that for a single patient, single service member. And so the effort was again, I can't take credit for it. Worked with a lot of very dedicated pilots and logisticians, and so at that point we had the airframe, so we didn't have the medics, and so to make that work, what we did is worked with Air Mobility Command, a guy named Doug Robb, who was my superior, if you will. He was the active duty in my role. And we worked out a deal, and that's really what it was. It was a deal that I would commit to a line of Aerovac critical care aeromedical transport team, but I got to fill it however I wanted to, because it typically been 90 days, and you can't take many physicians or other nurses or other medical staff out of their civilian jobs for 90 days and do it very often as volunteers. So we took that line and very consistently filled it with people for 2 weeks at a time. But these are people who were doing critical care in their civilian jobs. This was just they're doing it in the back of an airplane or in the back of a helicopter or some sort of means to get these gravely wounded, brave soldiers and Marines and airmen to critical care and Longstool. And then once they were stabilized, go Longstool to the appropriate hospital in the U.S. So we were able to fill that. And so we were not only able to have the Guard provide airframes to do so, we could provide very highly qualified medics. There was a big resistance because naturally, if you're on active duty and over there for 90 or 180 days and see someone show up and work their tail off for 2 weeks, then go back home, that was really the biggest resistance. And so 2 to 4 weeks was a typical deployment, though, and then they could come back in 3 months and do it again. So it was very self-sustaining, and I think worked well. And certainly the sons and daughters of America that were injured over there or became ill over there deserved the best care we could give them.
Well, I think it needed a person to spearhead the idea too. That was you have to have the medical background to understand that, which you did, but then secondly have the operational thought process, and that's what's right. Unique about John, I think, in that he obviously is a medical guy, but thinks like a pilot and like a leader in the Air Force, and always.
Yeah. Is that model still being used?
To my knowledge, it is. I think they're using the KC-130. Well, the Critical Air Access Team absolutely is being used. Our Critical Air Medical Team is actually being used. Of course, we don't have the hostilities quite to the level that we had previously, but no, they work 40-hour shifts. They'd fly from Longstool to Afghanistan and back all in one day, or some of them were based there, and they'd take an opportune airplane with these critically ill patients. Now, the not so ill, the people who, and it would be shocking if you saw the patient, you think, gosh, that's a critical injury. The aeromedical teams, normal aeromedical teams could manage those. And so that this is a separate program from that.
So for people who may not be familiar with the capabilities of the 135, you say over there and back in one day, how many flying hours are we looking at?
Well, we'd usually stop in Ramstein to pick up the equipment. So, whatever it took from, you go nonstop Forbes or wherever they were leaving from, there's other bases that did it as well. That's probably 11 hours or so there. And then they configure the airplane. And then, because it's the day before it left on that flight, it could have been refueling F-16s over North Dakota or B-1 bombers, B-2 bombers, as part of their mission set. And then they turn around, take off, fly to Ramstein overnight. Would be configured for aeromedical role, and then off would go. So, but it would fly in and back out the same day.
That's fascinating.
Yeah, it's pretty interesting, all that stuff. And eventually you retired. What year was that? You retired finally from the Air National Guard?
2012.
2012, yeah. And it got less fun for me after that. A couple of guys retired, and anyway, I still did it. But it was we had a great run in the years that I spent working directly with you, and
those were good times because we were actually making a big difference.
I think we were.
I think every day I felt like either in the operational role, interacting with bomb wing at Whiteman or the C-130 unit at St. Joe, trying to help them be able to do their job and mission, as well as the medical role. There was rarely a time where I didn't feel like we were making a big difference in not only the defense of the nation, but the care of those who protect it.
So I want to touch on the FAA stuff here in a minute, but it dawns on me. How do you manage all your time? I mean, you're busy. You've had a lot of stuff going on between the FAA, between the Guard, between private practice, between medicals, between life,
flying airplanes.
Yeah.
Well, one thing, I mean, to the aviation related, I mean, my parents are elderly and live in southern Oklahoma, and I can jump in the airplane in the morning, fly down there, spend a quality day with them, and fly back. Otherwise, it's almost a day going and coming.
Yes.
So it greatly improves my quality of life and being able to spend time with my parents. We will take a family trip to Colorado. I've got a son that lives in Colorado. We can get out there and spend some time and be back, where it's not to denigrate the airlines. I got two airlines represented right here, but it's a different process.
Well, that's why Todd and I are both airplane owners.
Yeah, that's why we
we get
the
it.
airplane business. Yes.
But anyway, that's what helps free the time I do have. There's really a lot of time management. I mean, I've already been on a conference call, managed, a lot of my duties this morning already, and it's 9:30 now, so I've been at it since about 5:30. So you do have to enjoy putting a lot of things in the day, and I think the aviation background is good for that, because again, in order to be in the Guard and have a civilian practice, you have to enjoy being busy.
Mm-hmm. Yeah. We get that question. I know you do too. You get that question a lot, and I'm not trying to pump myself up, but I get the question, Chris, how do you do that? And I think what it is it's a matter of priorities and a matter of focus, in that you're dealing with these two guys that I'm sitting here with are, they lean forward and they know what they're doing and they know where they're going, and so there's not a lot of, it's like I try to tell my kids, I'm like, you can spend all this time doing all this stuff that doesn't matter, or you can focus on something and really excel at it. And so I think, unfortunately, we have a society anymore that sits back and lets things be fed to them, as opposed to getting out there and doing something. So anyway, but hey, touch on your FAA responsibilities, would you?
Yeah, I'm a senior AME. I've been one since I got out of the Air Force in 1988. So been doing it a while. I perform first, second, third class flight physicals, do some aviation consulting. Enjoy going out and giving talks to aviation organizations. I'm on the EAA Air Medical Council, and have been for about 20 years, which is a unique opportunity because we interact directly with the leaders of the FAA, primarily medical certification branch, but the Federal Air Surgeon on a regular basis, and get to influence policy, at least in the EAA. You'll never hear our name involved with a new policy or a new program, because my thought on that is we want to be in the background, giving them advice, and then let them make the decisions. We don't pound our fist on the table. We meet with them socially and in a organized meeting. Both, which I think are both very important. I don't know which is more important of the two, but we know each other, and there's been some really pretty exciting things that have happened as a direct result of that relationship and our input. All of the group people in the Air Medical Council are pilots, and Dr. Steve Leonard is the chairman, and he and I are actually on the FAA Federal Air Surgeon Advisory Board. So we enjoy opportunity to interact and get our input on things as they're being developed, or if there's an issue. So
it's so important to have pilots who are in the advocates for pilots. You know what I mean? The opportunity to have people who understand the world from a pilot perspective, not just a medical perspective. So for that, that's valuable help to all of us.
Tying into what you do, and I'll leave the locations out, but as your role with a what would you call it, advisory group.
Oh yeah.
And so so many times, even just in civilian related things that involve aviation, there are so many people that have their fingers in the pie that aren't knowledgeable about aviation.
Mm-hmm.
And sometimes they tend to kind of squeeze the aviation minded people out. And I think that's when we end up with a lot of bad policy and a lot of bad decisions that affect airports, that affect the way you and I fly and what we want to do.
Yeah, that's exactly right. The people that make those decisions aren't really bad people. They just don't have the right input, and given the right opportunity and the right knowledge set and a cordial and relationship with the people that are trying to help them succeed is very valuable. And I think the enlightened leaders that do that really fare much better, because they're able to, again, a cordial relationship. It's not, pounding like our fist on the, there's no adversarial. There's no headlines sent out to the pilot base saying, FAA or any other group. None of us like to be told that we're not doing a good thing or conspiring against people, when really their duty and lives are spent actually facilitating what all of us like to do, is safely fly and utilize civilian aircraft to achieve that.
Now you've spoken at Oshkosh at AirVenture in the past, and are you still doing that any? Or would any of our listeners potentially see you this summer? Or is there any of that going planned?
Yeah, there's the council meets we have an open forum typically twice during AirVenture, where we have a talk. That's been, because of the internet and other means of getting information, that has been pared back a little bit. We used to do it a lot more, because you get very basic questions. People wouldn't have access to the information, or their local AME may not be knowledgeable, or worse yet, say, gosh, your flying days are over because you have, and back in the day, high blood pressure was the thing. So 20 years ago, I'd get up and give these talks, and you'd be answering questions about things that, again, a quick search of the internet will get you a pretty good answer. So those sessions became a little less attended, so they were spaced out a little bit. But what we do every year is we have a series of it's called Ask the Expert. And so they put us at a little table in the EAA pavilion, and we talk one-on-one with the pilots that have a question. And sometimes it's simple questions, but frequently it's questions of somebody who maybe have gotten some bad advice or misread one way or the other the regulation, and either think they're fine to fly when they're not, or think they're not fine to fly when they are. So we do that, and that relationship I spoke of that we enjoy with the FAA. There's been multiple times where I've talked to somebody, they've had an application in, or they put an application in, or they're about to, or they're waiting on something, and I'll contact the FAA right there on the field, and before the day's over, they've got a medical certificate in their hand.
Wow!
So that's happened multiple times.
Yeah, that's a great advocacy right there.
Yeah.
That's and that, to me, this leads us into kind of a discussion point that I know, Chris, you have some interest in, and that is just what's some broad advice you would give to pilots, be they student pilots, private pilots, whatever, that things to avoid, things to we've talked about ADHD medicine or DUIs or whatever other thing. I don't know if you want to have any thoughts broadly. I don't mean for you to give a medical clinic here, just what can people do?
Well, sure. Again, the FAA is primarily concerned, and when we're talking about FAA type things, of course, as a flight instructor, I've seen people do plenty of stupid pilot tricks, but we
were looking at a picture of one this morning.
Yeah, that's right.
So the But the thing for the FAA is, and a lot of student pilots, I do quite a few student pilot exams, is their physicians in general have been quicker to diagnose and pharmaceutically treat some conditions that in the past, we would have been told go take a walk or studies pointing towards the wall so you're not distracted with like ADHD, and so they've been put on medications for that, or little feel blue someday and get put on an antidepressant, and without any real testing or real diagnosis. And I've had these pilot applicants, sometimes pilots, come in and say, yeah, but I feel better on amphetamines. I said, listen, buddy, everybody feels better on amphetamines. So I said, this is a problem. So recently, and this is with something I think that the EAA, we've been working with the FAA, and there is a process, for example, for ADHD, if you haven't been taking it for a few years and certain criteria are met, pretty liberal criteria, I mean, not real restrictive. You no longer have to go to a specialty AME and see a psychologist and all that. It's not impossible to get certified on those medicines, but it's very difficult, and as same with antidepressants. Now, these are all new things, but this is ground that's been broken in the last few years. So, again, if you need those medications to survive and enjoy your life, that's great. That's what they're for. If it's an optional sort of thing, I'd consider doing it without medication. Again, not endangering yourself or those around you, but I would, try to stay off those medications if you can. And they say, go for a walk. There's a reason. Walking, exercise helps anxiety and depression, that sort of thing. So looking for, when appropriate, non-pharmaceutical treatment for common problems.
So are they authorizing at all you to be actively taking those medications and allowed to fly, or is there a waiting period after that you?
It's in the book to, I was talking about ADHD. It's in the books that you can. I've never seen anybody authorized on it, quite honestly. And the process, and not to say it hadn't happened, but the process is pretty intensive, expensive, and we'll have a shorter leash on that. And there have been some high-profile accidents. I won't go into those, but where it's pretty certain that somebody did have a mental issue in the front of the airplane that has, I think, slowed down the process of accepting these medications.
Yes.
So there's a reluctance to move too fast on these. So the thing I'll kind of on the other direction, Chris, is there's things that I still get pilots come in saying, they're going to put me on blood pressure medicine at the end of my flying days. The FAA has become very enlightened that, it's much better to treat high blood pressure. Two things. One is it's better to treat it and avoid the complications. I mean, you don't want to have a stroke in the air. You don't want to have aortic dissection. You don't want your kidneys to fail over a period of time. And the second is our medicines simply are better. The medicines I was using 30 years ago did have some side effects, 30, 40 years ago. And the newer medicines are very low in side effects. And the FAA recognizes that and really puts that. The blood pressure program is what we used in getting the CACI, Conditions AMEs Can Issue program started, is that high blood pressure was the first program where they didn't require the FAA to issue a waiver for treatment. And so we said, well, gosh, if now that you're allowing us to do that and we've shown that we can do it responsibly, why don't we have some other topics? Now there's 27 wow. Conditions AMEs can issue. Every single one of them required a special issuance and months out of people's lives. Now you have to meet criteria. And here's a insider tip, is if you just go to Google and type in FAA AME guide and the diagnosis, it will bring up exactly what I see in the AME guide. And so you can, if you say, gosh, ADHD or coronary artery disease, now there's no CACI for coronary artery disease, but you can see right there in black and white. And that's what I do when someone comes in with questions about whatever the condition is. So I go straight to there, print it off, hand it to them and say, this is straight from the horse's mouth. You can see exactly what the AME sees and know what the requirement is. And importantly, take that to your doctor, let them look at it and say, if it says you need 8 things, you need all 8 of them. You can't do 7 and leave 1 empty. So you put a check mark by each one of those things as you're doing it. And it's really facilitated the process. The other thing that's facilitated the process is now we can scan and attach small files, up to 8, I believe, with to the application, rather than taking the application, electronically send it in, have the airman put it in a FedEx package, and everybody keeps their fingers and toes crossed, hoping that someday the 2 of them get together, the package and the file. So now it all shows up in one basket. The reviewer can look at it and determine a special issuance or not.
Do you have any other examples besides ADHD things that?
Well, depression is one. Again, there are people flying on antidepressants, but that's a more extensive evaluation. But that's I mean, I remember a federal air surgeon said, we'll never certify that. And that was a few federal air surgeons ago. But now, I mean, with the proper monitoring and proper treatment, that can be certified. People with certain kinds of kidney problems, people that have had prostate cancer, people who've had some other malignancies. Very recently, they just certified some weight loss medication, which I thought would never happen. So that again, criteria have to be met. AME's got to review it, certify it, but that can be done easily during the exam. They want to prove in that case that you don't have diabetes and you're not trying to fake them out saying it's for weight loss when it's really for diabetes. And so the diabetes but a lot of people are flying with diabetes, and the people that fly for a living, we're able to get special issuance. Some third class still want a special issuance. A lot of them have gone to Basic Med. Basic Med's a great program for a lot of those diagnoses that the family doctor can sign off, knows the condition well, and hopefully is responsibly saying yes or no, whether they can go ahead and fly their planes.
I'm still old school. This goes back to joining the military in 1988. I just don't want to be on medication if at all, and I'm not. And but that's encouraging.
That's what you say in front of your AME.
Let's get that on record.
No, it's all rattling. I heard in that bag you brought in.
No, I really am. And talk about the weight loss thing. Chris and I, as you know, being big fat guys like we are.
Used to be
trying to lose some weight, but that was the first thing off the table. I'm like, no, I don't want it. I'm this doctor supervised stuff, but I don't want to be on any medication to do it. So far, so good.
Yeah, it's like you're doing well.
Yeah. So, well, that's interesting. So, you got guys come in and out of your office all day long doing medicals. I'm curious, what are you seeing? Is there any area that they're being denied more than another?
Yeah, well, historically, I have to say that the biggest reason people lose their medicals is cardiac issues. So they've had the disconnect on that is that somebody may have coronary disease and say a 65% lesion, and the medications and treatment for partial obstruction of coronary arteries is much better than it used to be. And so to say a 50 or 60% lesion, the cardiologist may say, gosh, we could treat that in medicine. And they have good data, for example, showing that people do as well or better with medical treatment than putting a foreign body of a stent in there, or certainly surgery in a lot of cases. And so there's a difference of opinion. FAA says that that's fine, but we're not going to certify it, especially if you're flying, like you guys have a plane full of people behind you with that increased risk. No doubt it's an increased risk. The cardiologists stratify that risk a little differently, and again, they're not bad people. They just don't think about a low oxygen environment, high stress at times. So the FAA, for good reason, typically will require treatment that their cardiologist, very capable, astute cardiologist, may disagree with. So that's the thing I see with the biggest issue. The other thing I see is almost any neurologic issue is a problem. I mean, because again, sudden incapacitation is a big deal, and so if somebody has had seizures, for example, as a child, may have outgrown it. Again, have they been put in a low oxygen environment? Have they, subject to rapid decompressions? Are they, a lot of things that as pilots we have to think of, and certainly as professional pilots and pressurized aircraft is a risk. And I get parents really upset. Said, I've always told my son or daughter that there's nothing in this world they can't do, and you're telling them that they can't be an airline pilot. Or, and I go to bat for every single person that comes in. I'll send it to the FAA, put it as true, but as positive as we can. There's just some conditions, and if you think about it, neurologic, cardiac, they worry about mental illness and some metabolic things. So anything is going to be prone to sudden incapacitation.
Interesting.
That is really interesting. I always learn something from Dr. Owen.
So let's pivot here a little bit. Let's talk about some little lighter subject, maybe some general aviation stuff. So some of your flying, and just a super light topic. But what's your favorite airplane to fly?
The plane that Todd bought from me.
Yeah, I felt that was coming.
It's an RV-8. Yes. Great airplane.
It's an annual right now, but when it's not an annual, it's fun.
When you're not writing checks,
it's a fun airplane. It's been a good time for me. I'm glad, and I'm sure Bonanza would be high on your list too.
Yeah, love Bonanzas. Recently started flying Cirrus some, and enjoy that. It's a different kind, a little bit different kind of flying, but it's much more responsive and enjoyable flying it than I would have actually thought.
Yeah, that's good. Say, and one point that listeners might find interesting is that you actually, for a period of time, flew there. So there's a children's hospital in Kansas City, probably nationally known, I would say. It's a very good Children's Mercy Hospital, and they had an aviation. Well, and I'm speaking a little out of school, but sort of an aviation department where they had airplanes and you flew that for a period of time.
Right. For about 3 years, I flew a King Air. We started off in a King Air 90 and then moved to a 200. Only twice did I ever have to come out of my role as a pilot and help as a physician in the back. But that really wasn't my job. My job was to safely get them to and from where they needed to be to help these children. So did that. It was a company that contracted with Children's Mercy.
That's what
Then about that time, I got promoted in the Guard, and there wasn't room for my civilian practice, 200 paydays with the military and flying for Children's Mercy. So I had to give that up. But I enjoyed the 3 years. I enjoyed a little less when you'd land someplace at 2 a.m. The FBO would be closed and set out in 20-degree weather in the airplane. But I mean, it's good stories now. Back then, it wasn't quite as fun.
So in case you've lost track here, okay, we've got family doctor, we've got Air Force fighters, we got medical or Brigadier General operational kind of a general. We've got corporate pilot. We've got I'm losing track.
Well, see, I'm trying to figure out. So we got. Do I call you John? Do I call you Captain? Do I call you Doctor? Do I call you General? Is there anything I'm missing there, Mister?
Actually, I did want because so you've recently been flying, I think, a Citation some. I'm not too up on that portion of your gigs. What can you talk about with regard to that?
It's an SIC position. Yeah. The PIC was. Could have done that, but it was that was more time consuming, and as SIC did the course and was able to get the type rating and as a contract pilot for a local Part 91 equity share type of organizations.
Nice.
That's
Nice.
neat. Well, we're getting close to that time, believe it or not. To kind of wrap this up, I want to leave you with any final thoughts or any words of advice or anything that you want to leave.
Oh, that's interesting. I guess I'd say, focus and energy, whether it's in medicine, military, hospital administration. We kind of left a little bit of
Oh
that
yeah,
out.
we didn't talk about that. I forgot that job.
Yeah, trauma type of thing. It's all, and I think there's an awful lot of parallels between emergency trauma type of activity, work, and flying. It's a lot of time you're not doing a lot, and other times you're required to be absolutely on your best game. And I just finished working a couple of days of 12-hour shifts in the trauma center, and that's what keeps us coming back. Is that and that's the reward of focus and hard work, is that you have entertaining and enjoyable lives, and if you get to help someone along the way, which has been what I've really strived to do in everything and all that I do, then that's a real tangible bonus.
I can't let that go for a minute though, because that in a nearby town, had a hospital that was having problems in the emergency department, and Dr. Owen took over that and turned it around. I mean, literally turned it around. So I think the key takeaway, hopefully listeners are getting this out of this whole thing, so this isn't just like a dude who has titles. This is a guy that made a difference in every title, and I consider you a great friend, and you've been helpful to me on a personal level. Appreciate the airplane too. He didn't give it to me. I can tell you it's not a fair price, but they've all gone up since, so it's worth more. No, but seriously, your accomplishments are an inspiration, and I hope the listeners really get that out of this discussion.
Me too. You wanna close us out here then?
Well, you just
kind of did, I guess.
Yeah, I think that. Thank you, General, for coming in. I call you General sometimes. I call him Doctor sometimes. I just have fun with it.
That's the G-rated thing you call me.
No, thanks very much. Thanks so much for joining us. We've enjoyed this discussion very much, and I really believe our listeners have too. And they can find you again, ATD Flight Systems. As if you just want a flight physical or need a good evaluation on a medical issue, you'll get a fair evaluation, is my point. So you want to remind us again how to contact?
Well, I do the flight physicals and air medical consulting out of ATD Flight Systems. It's a flight school charter operation here in Kansas City. You can Google it. I was telling them earlier, I have trouble with the phone number because it's just the exact inversion of one of the airplanes I fly. So but anyway, it's easily Googleable. You can easily Google it. It's ATD Flight Systems. Great place.
That's a great point. That when a guy's mixing up his N number with his business number, you're talking to the right person. So anyway, thank you, General, and we do appreciate you coming on.
Yeah. My pleasure. Thank you,
Doctor. Thank you. This is great. This is very enlightening. And so maybe I know that, like you said, I think we may have left a bunch of stuff on the table. Maybe we can continue this at some point.
Okay.
Yeah, so
anytime.
But anyway, thanks to our listeners. You can always find us at flywildblue.com. Phone number 816-479-2723. We got Chris Kirk and Todd Mitten here. Give us a call. And again, thank you for subscribing and for listening.
Thanks for listening to the Wild Blue Podcast. Find us online at flywildblue.com. And don't forget to subscribe and share.